You know, when it comes to managing pain during labor, there's one name that everyone knows: the epidural. It's been the gold standard for decades, and for good reason. But what if that gold standard could be even better?
So let's get real for a second. While the epidural is an absolute game changer for most people, it's not always perfect. It has some limitations that can lead to frustration and pain, which made researchers wonder, can we actually improve on this cornerstone of obstetric anesthesia? And we're not talking about a tiny problem here. A huge study from 2022 by Berger and his colleagues found that up to 13% of standard epidural catheters just fail. They have to be completely replaced. I mean, can you imagine going through that whole procedure twice? That's a pretty big number, and it really shines a light on the need for something better.
And that something better might already be here. It's a twist on the standard technique, and it's called the Dural Puncture Epidural, or DPE for short. And it's designed to tackle the exact issues that can sometimes make a regular epidural fall short.
So here's what we're going to cover in this explainer. First, we'll look at the limits of the standard epidural, then we'll get into what exactly the DPE technique is, we'll explore the case for it, dive into the controversy around it, see how doctors are optimizing it, and then we'll give you the final verdict. All right, first things first, let's really dig into the problem that DPAs is trying to solve. I mean, this is a technique that's used millions of times, so why does it still need improving?
Well, the classic lumbar epidural, or LEA, has a few well-known quirks. Sometimes it can take a while to really kick in. Other times, the pain relief can be patchy, stronger on one side than the other. It can also struggle to numb the sacral nerves, which becomes really important later in labor. And of course, like we just saw, the catheter itself can fail, which means starting all over again. So how in the world does DPE fix all that? Well, it all comes down to one tiny but really significant change to the procedure.
The dural puncture epidural is pretty much what it sounds like. Once the main epidural needle is in the right spot, the anesthesiologist pushes a super thin spinal needle just a little bit further to make a tiny hole in the dura. That's the membrane around your spinal fluid. Now here's the key part. They don't inject any medicine through that tiny needle. And that's what makes DPE different from another technique you may have heard of called the combined spinal epidural, or CSE. Let's break it down side by side. With a standard epidural, you stop in the epidural space, thread the catheter, and you're done. With DPE, there's just one extra step. You puncture the dura with that tiny needle and then pull it right back out. The whole idea is that this tiny little hole allows the medicine from the epidural space to sort of leak into the spinal fluid, which in theory should create a much stronger and more even block. Okay, that modification sounds pretty clever in theory, but what does the research actually say? Let's look at the evidence that really makes a strong case for DPE. So, one of the biggest arguments is about that catheter failure problem. Remember that big 2022 study we talked about? It directly compared the two, and the difference was pretty clear. DPE had a failure rate of just 6.5%, while the standard epidural was up at 9.8%. That's a serious drop in the number of people needing a do-over. And it's not just about the catheter staying put. Other studies suggest DPE is just better. Research from folks like Shirawi and Song found that it can bring on pain relief faster. In a 2017 trial by Chow's team, discovered that DPE gave a more reliable block of those tricky sacral nerves, which helps fight that whole patchiness problem. So let's recap. Lower failure rates, faster onset, better coverage. This sounds like an open and shut case, right? A total no-brainer. Well, this is where the story gets interesting, because not all the evidence is pointing in the same direction. And this brings us to a really powerful counterargument from a major study published in the journal Anesthesiology in 2022. Tan and colleagues ran a big trial with obese pregnant patients, and they concluded there was just no clear clinical benefit. Wow! That finding flies right in the face of all the promising results we just saw. And they're not the only ones. When you start lining up the results from all these high-quality trials, you get a really mixed bag. Shirawi found it was faster, but Chow didn't. Heezen's big meta-analysis in 2019 said the block quality wasn't really better. And then Tan found no benefit at all in a specific group of patients. This right here, this is the heart of the debate. So this just begs the question, what is going on? How can all these carefully designed studies, looking at the exact same technique, come to completely different conclusions? What are we missing here? Well, it turns out the devil is absolutely in the details. There are a bunch of key variables that can totally change the outcome. For example, some research hints that the size of that tiny spinal needle actually matters.
A slightly larger 25-gauge needle might work better than a smaller 27-gauge one. But you've also got to consider things like the specific patient group, how much medicine they get up front, and even what the study was trying to measure in the first place. All of these can sway the results.
But here's the cool part. This controversy isn't stopping progress. Actually, it's doing the opposite. Researchers are using all this messy data to figure out how to make DPE work best, fine-tuning everything from safety protocols to drug dosage. Okay, the first question on everyone's mind is, if you're intentionally poking a hole in the dura, what about those awful spinal headaches? Well, here's the good news. Multiple studies, including that huge burger trial, have found no significant increase in post-dural puncture headaches. It seems the needles they use are just so tiny that they don't cause a problem. And the technique itself is getting way more precise. For example, there's a modern delivery method called a programmed intermittent epidural bolus, or PIEB. A 2023 study by Zio and colleagues actually calculated the exact optimal volume for it to be 90% effective is 11.3 milliliters. This is the kind of super specific data that helps make the technique better and more reliable in the real world. All right, we have seen the good, the bad, and the confusing. So after all of that, where do we actually land? What is the final verdict on the dural puncture epidural? Let's just boil it all down. On the pro side, you've got a potentially faster, better block with a more reliable catheter. Plus, seeing that tiny bit of spinal fluid is great confirmation for the anesthesiologist that they're in the right spot. The biggest con is that the evidence is all over the place. The benefits just don't show up every single time. And in the neutral corner, it seems to be just as safe as a standard epidural when it comes to headaches. So, the takeaway is really this. DPE is not some magic bullet that's going to replace every single epidural tomorrow, but it is a very, very promising tool in the toolkit. For patients where a difficult procedure is expected, or for those who are at a higher risk of catheter failure, it offers some real advantages that could make all the difference. And all of this leaves us with one final big question. As scientists keep fine-tuning things like needle size and drug dosages, and as more and more research comes out, we have to ask, are we just watching a niche technique get a little better, or are we actually witnessing the rise of the next gold standard for pain relief in labor?